Hello, everyone, and welcome to this lecture on intrapartum fetal monitoring. Our learning objectives today are to highlight evidence-based practice in assessment and interpretation of cardiotocography, or what we call it the CTG, during labor, and to outline the recommended management of intrapartum CTG abnormalities. Intermittent auscultation is recommended only for low-risk labor. This should be performed using either a Pinard stethoscope or a Doppler device, which is the handheld Doppler, or Dopplex, after palpable contractions for at least 1 minute. The recommended frequency of intermittent auscultation in low-risk labor is every 15 minutes during the first stage of labor and every 5 minutes in the second stage. It is essential to palpate the maternal pulse alongside with a fetal heart rate. If the baseline heart rate increases by 20 or more beats per minute, or if there are decelerations that are heard, more frequent auscultation should be done. For example, you do an auscultation for 3 consecutive contractions, and if you think there are still persistent abnormalities, you should switch to a CTG or continuous monitoring. Continuous CTG is only recommended for high-risk pregnancies or in high-risk intrapartum events, such as fevers, meconium, or any change in maternal observations that is concerning to you. We also do continuous CTG with oxytocin and epidural as well. It is important to support patient decision-making regarding fetal monitoring, as continuous CTG increases the likelihood of interventions. Maintaining CTG records is essential for documentation, so always avoid discarding CTG records. So it's important to say that continuous CTG is only indicated in high-risk pregnancy and labor. But if a woman says that she wants to have a continuous CTG, even if she's low risk, it's fine. It's still her decision to do that. But you have to highlight that this will be on the expense of more interventions or more likelihood of interventions, and it does not improve the outcomes in low-risk labor or low-risk pregnancy. So I would say continuous CTG is only recommended for high-risk pregnancies or high-risk intrapartum events, as we mentioned. So the indications of continuous electronic fetal monitoring include high-risk pregnancies such as pre-existing diabetes, gestational diabetes requiring medications, hypertension, prolonged rupture of membranes that exceeds 24 hours. That's very important. So any rupture of membranes that's more than 24 hours should be monitored continuously. Significant blood loss, suspected infections, or pregnancies beyond 42 weeks. Very important if there is uterine tachysystole as well. So women who have 5 or more contractions in 10 minutes should be continuously monitored. Additional indications of continuous electronic fetal monitoring includes the presence of meconium-stained amniotic fluid, maternal pyrexia, pain that's unrelated to contractions, so pain in between contractions or constant pain, maternal heart rate that's more than 120 per minute on 2 occasions within 30 minutes is something that we need to also use as an indication for continuous fetal monitoring. If a woman has hypertension, meaning that she has 2 occasions of blood pressures more than 140 and or 90 for the diastolic, as we said, in 2 occasions within 30 minutes, or if they have proteinuria of +2 or more, or if we start giving them oxytocin administration. Of course, with the blood pressure, we have to say if we get the blood pressure that's more than 140 over 90 in 2 occasions, but if you get a blood pressure that's more than 160 over 110, even if it was just 1 occasion, you have to start continuous monitoring. So as we mentioned before, oxytocin administration is an indication, epidural use because of the hypotension and CTG changes associated with that. And any delay in the first or the second stage of labor are indications for continuous fetal monitoring. So the presence of meconium may indicate fetal compromise, and it is associated also with the risk of meconium aspiration syndrome. It's more common to see meconium in post-term pregnancies, but even if that happens, you don't have to just take it as a physiological thing. You still have to do a full assessment to rule out any sort of fetal distress. So general recommendations for CTG include performing a fresh eye assessment every hour with an in-person review and differentiating between maternal and fetal pulse rates at least once per hour. So you always have to document clearly that you were able to say that the fetal heart and the maternal heart are definitely different, at least once every 1 hour. Because as we know, sometimes you beacon the heart rate of the mom. It's not uncommon for women to be tachycardic at the time of labor. And their heart rate, sometimes if they are a little bit dehydrated as well, it can go up to like 110 or 120. And you may back up the pulsation from the mom as a fetal heart. And if that's the case, you're just monitoring the baby, thinking that the baby is fine. And unfortunately, you're not monitoring any sort of a heart rate. And the baby may be in complete distress or maybe even an intrauterine fetal death without really knowing. So that's very important. And the importance of a fresh eye is another thing. So the one who is doing the interpretation of the CTG, sometimes if you're working in a setting where midwives are competent enough to do that, then they do it. But you still need the midwife in charge, the one who is like doing the one-to-one care with the woman who is in labor. She should be the one who's doing the continuous assessment of the CTG, but you just need a fresh eye um, of someone else who hasn't been in the care of this patient to come have a look on the CTG, because that helps to minimize the misinterpretation of the CTG. The fresh eye always gives you another perspective, um, just because, if one person just doing the whole interpretation, there may be mistakes that are repetitively done, or maybe they are just having something in mind that everything looks all right, but they don't see the full picture. So it's always good to get a fresh eye to be sure that everything looks all right. So when you read the CTG, you have to check 4 domains to decide on the right category of the CTG you're reading. Each domain should be subclassified to either being white, amber, or red. So the white is a good thing, the amber is an intermediate, and the red, of course, is a bad or dangerous. So the first domain is contractions, which is something new. I mean, it has been added recently to the CTGs because many times we miss considering the frequency of contractions as a part of the assessment of fetal well-being. So that has been added and has been used to classify as well. So if the contractions are less than 5 in 10 minutes, this is white, which means good. If it's 5 or more contractions, or a hypertonus when there is like continuous contractions, no resting, this is called amber. We don't have red for contractions, so it's either white or amber. So the second one is the baseline heart rate. And to assess a baseline, you have to see the average of the heart rate after like ruling out any periodic changes. Periodic changes means accelerations or decelerations. So when you read the CTG, take the accelerations off, take the decelerations off, see what's the rest of the CTG, and take the average. And to do a right assessment of the baseline, you have to assess that over a period of 10 minutes. To take a 10-minute segment of the CTG to decide what the baseline is. So the normal baseline should be something between 110 to 160. So if the heart rate is like that, it's white. It's amber if it's 100 to 110, or if it raises at least above the previous baseline at the beginning of labor by at least 20 beats per minute. So for example, if the heart rate has been always 120 at the beginning of labor, or like when you admit the patient has been like this at the beginning, and then later on it starts to shift up to the point that is now like 140 or 145. So compared to the baseline when labor started, or prior to labor as well, you see a change that's more than 20. So if you see a change that's 20 or more, just on one side, so basically it's 20 or more increase, not decrease, increase in the baseline. This is another sign that we classify as amber. And if that happens in the second stage, actually it is classified as red. So as we say, baseline, you assess over 10 minutes, 110 to 160 is white, 100 to 109 is amber, and if the baseline increases by 20 or more, that's still amber. So when it gets the mark of red, this is when the heart rate is below 100, or if it is above 160. So third is a variability. That's the third domain. So it should be something between 5 and 25. And typically to assess the variability, we assess a segment of 1 minute, see what's the minimum within 1 minute and what's the maximum within 1 minute. Of course, excluding accelerations and decelerations. So you take that segment, see what's the highest value, well, like what's the highest number, what's the lowest number, and if you get numbers between 5 and 25, this is white. However, if you get a variability that's more than 25 minutes for up to 10 minutes, this is called amber. So increased variability is also a warning sign. So if the variability increases above 25 for less than 10 minutes, is considered amber. If the variability is reduced, meaning that it's less than 5, and this lasts for at least 30 to 50 minutes, this is called amber as well. What if the variability is less than 5 for less than 30 minutes? It should be fine because we count that likely as a sleep cycle. But if the variability is less than 5 for a period of 30 to 50, it's kind of borderline because it could be still a sleep cycle, but something that's worrisome because it takes longer than average. So in this situation, we call it amber as well. However, it becomes red if the variability is more than 25 per minute for more than 10 minutes, or if it is reduced less than 5 for more than 50 minutes, because it's very unlikely for this to be a sleeping cycle. Or of course, if there is a sinusoidal rhythm, and the sinusoidal rhythm is basically like a sawtooth appearance when they're like very regular ups and downs, limited ups and downs, with really no periods of acceleration. So this is typically a sign of probably a fetal anemia. So the fourth one, which is of course decelerations. Of course, to count anything as a deceleration, that means a drop in the heart rate, in the baseline heart rate by at least 15 beats per minute, and this should last for at least 15 seconds. So anything that's not like this is not a deceleration by definition. So early decelerations are always white. The deceleration, this mirror image, starts with a contraction, ends with the end of the contraction. It's called early deceleration, and it is white. It's not concerning. Similarly, variable decelerations without concerning features are also white. But what are the concerning features? I'll tell you in a minute what are the concerning features. But if you don't see any of the concerning features we're going to discuss later, the presence of variable decelerations, no matter how long they stay, should be fine. So if you see variable decelerations with even one concerning feature, it is a problem, and we'll discuss that as we go. So if concerning variable decelerations, let's call them like the evil variables. So the variable decelerations that are evil, that are ugly, because they have concerning features. If these evil variables are repetitive, but happening for less than 30 minutes, it is amber. And when we say like these evil variables are repetitive, this means they happen in more than 50% of the contractions. So evil, repetitive, but less than 30 minutes, they are amper. Evil variables, not repetitive, greater than 30 minutes, still amper. But if evil and repetitive and more than 30 minutes, this is when they are red. So basically, variables that are not evil, no concerning features, are fine. Variables that are evil because they have concerning features, if they are repetitive, less than 30 minutes, amper. Non-repetitive, greater than 30 minutes, amper. But if both of them, repetitive and more than 30 minutes, and evil, of course, this is when we call them red. So if they have both the features of being repetitive and more than 30 minutes, this is when we call them red. One feature, not the other, then it's amper. For late decelerations, if repetitive but less than 30 minutes, they are amper. If greater than 30 minutes, of course, they are red. Of course, has been said, any prolonged deceleration that's more than 3 minutes is considered red, for sure. And if there is bradycardia, because we mentioned that if the heart rate is less than 100, then it is red as well. So, as we mentioned, the intrapartum CTG assessment involves the evaluation of fetal heart rate patterns in response to contractions. So, repetitive decelerations occurring with more than 50% of the contractions are concerning. So, when we call repetitive, this means more than 50% of the contractions. The concerning features or the specific features of concern are prolonged decelerations more than 1 minute. So if you see a variable deceleration that lasts more than 1 minute, that's a concerning feature. If you see reduced variability within the deceleration itself, when you have a look on the deceleration, it's pretty smooth. It doesn't have variables within the duration of the deceleration. That's another concerning features. Absence of shouldering, the shouldering is a rise in the heart rate at the beginning and at the end of the deceleration. I will show you that in a minute. So if there is no shouldering is a good sign because accelerations are always a good sign. But if you don't see the shouldering that was seen before, then it's a concerning features. And intuitively, the last one would be failure or slow return to baseline. So the deceleration is either more than 1 minute or just slowly coming back to the baseline or never recovers to the baseline. So any of these is a concerning feature, and this is the evil variables we talked about. Accelerations, as you probably noticed, accelerations are not counted as one of the domains of reading a CTG, which may look strange to you guys, but basically we still see accelerations as an important sign. It's a sign that the baby is healthy, even with reduced variability. So their absence, if normal trace, doesn't indicate acidosis, and this is a thing. That's why we don't include it in the interpretation, is because absence of accelerations is not a warning sign, and it's hard to just take it as one of the ways to categorize, but you can take it as a reassuring feature. Sometimes you see variable decelerations, or sorry, you see like reduced variability, but you still see accelerations. If you see accelerations, that means the baby is probably fine. It's very unlikely for the baby to have any problems. So you still have to consider accelerations, because if you see concerning signs in the CTG and you don't see accelerations, that's an important sign that will make you more worried. And the other thing which is very important is sometimes we have to bring the accelerations to be happy. So especially when you see reduced variability, one of the things you can do, if the only reason why the CTG doesn't look right is because of a prolonged period of reduced variability, you're trying to do an examination and scratch the head of the baby. Because when you do that, you're likely going to stimulate accelerations. You're waking the baby up, and with that, you typically see accelerations. But if you do that and you do a very vigorous scratching to the head and you don't see any accelerations, that is a concern. That's probably a confirmation of your concern because you cannot see even induced accelerations in the presence of reduced variability. So let's review these variable decelerations, just a way of illustrating what we have discussed. So we can see the shouldering in the first one. So as you see, with that probably, as we see it here, so that is typically what we call it shouldering. So as you see, you can see shouldering here at the beginning, at the end. You may see a little bit of variability within the deceleration itself. I mean, like this, we can see here that we can see like some sort of variability within the deceleration. But for example, like in this one, we can see like a deceleration is completely smooth. There's not much of a variability in it. So you can see the shouldering. As we said, that's an accelerative sign. So that's a good sign. So that's positive. We have to check the length of the deceleration. So each box of those corresponds to 1 minute. So a deceleration like that, I mean, every time you see a deceleration, you have to see how long it lasts. Very important. So for example, we check on this deceleration. It looks like it is still within 1 box of the CTG, which means, of course, depending on how you're adjusting the rate and everything, but I mean, in this CTG, that's 1 minute. So it still looks like the deceleration is still within the 1 minute area. So that is another sign that it's not a prolonged deceleration. So as we mentioned, going back to this one, we still have the problem of reduced variability. I think in most of these, like for example, this one looks really like reduced variability within the deceleration. So that still counts as a concerning feature. So in this CTG, please check the highlighted decelerations. So yeah, let's see that deceleration, for example. So as you see here, I don't necessarily see any shouldering. Like if you see this decel, maybe a little bit of this, but I mean, this deceleration goes down and then come back up and there's no shouldering, it just comes back to the baseline and that's it. Of course, if you see, you have to check what the baseline is because it looks like it's high here. It's like almost 170. We have to really rule out the decelerations and take the rest. So if we take like this segment, for example, to see where the baseline is, and just try to draw a line, and probably going to be something around 170. So it's concerning when you see a heart rate that's 170. It's basically a red sign. But we don't see any shouldering with these decelerations. Similarly, I don't see any shouldering here as well. Don't see any shouldering here as well. I mean, I can see some probably good variability within the deceleration, but still, I don't see any shouldering. The other concerning feature is if we try to calculate the duration, I mean, probably this deceleration is a bit more than 1 minute. Of course, that box corresponds to a 1 minute, so that is a little bit more than 1 minute. I just want to highlight one important thing, pretty much important, is every time we watch a deceleration, we have to know when exactly it comes back to the normal baseline. Some people just do not realize where the baseline is. So once the heart rate goes down to 100, they get really worried. And then like slowly, it comes back to become like 140, for example. And then they feel, okay, the deceleration has gone. Now it's resolving. Now it's becoming normal again. But that's not true. Let's see this example. So here is a deceleration. It happens here, came back to almost like 140 or something, then deceleration again, coming back to almost 140 or 150, deceleration again, and now going up to almost a 170. So as we mentioned earlier, you have to know what your baseline is before you do any sort of interpretation. So I know the baseline here was 170. So this actually never recovered to 170. Even it looks like it is now within a normal range, but we know that's not the normal range for this baby because it was 170. So this means you cannot count that as a normal recovery. And actually, you may have to consider all this as a single deceleration that never recovered to a baseline. This means that's an actual prolonged one. And we mentioned that one of the concerning features is either a duration that's more than 60 seconds or slower return to baseline or even complete failure to return to baseline. So please, if you see something like that, don't take a breath and say, okay, it normalized and has another deceleration, normalized and had another deceleration. Actually, this baby never recovered to a normal heart rate, I mean, to its normal heart rate for probably like, if I count that, like almost 1, 2, 3, 4, 5, 6 minutes. So that's pretty a long duration. So we have to be mindful of that. And of course, in this CTG, the deceleration, um, where we can tell comfortably that this deceleration has no shouldering. That's obvious. But most importantly, it is more than 1 minute. So again, that is a 1 minute. That deceleration is definitely more than a 1 minute. And it's slowly, because I mean, it's basically slowly recovering to the baseline, as you see. So, and we can see like this type of decelerations, I can tell definitely they are repetitive. So these are the contractions 1, 2, 3, 4, 5, 6, 7, 8, 9. And I can see almost like 8 deceleration. So almost with every single contraction, there is a deceleration. So this is definitely repetitive, and this is really concerning. So these are repetitive with concerning features. Um, it's almost, I mean, it's always good to just see the variability because I mean, like this is an example of good variability within the deceleration. So just in contrast with the ones that I showed you earlier, this is like variables within the deceleration, which is good. But again, you just need one concerning features to say that these CTG, like these variable decelerations are not acceptable decelerations or are not white, if that makes sense. So just to say, as we mentioned, accelerations indicate fetal well-being even when variability is reduced. However, the absence of acceleration and otherwise normal trace does not necessarily indicate acidosis. We kind of mentioned that earlier, but I have to just highlight it one more time. And that's why I didn't really highlight any sort of like if accelerations are present or not. But most of the CTGs that we have seen did not actually have accelerations because it's very unlikely to see a CTG like that. Doesn't look so great. And then you see an acceleration, very unlikely. So when you assess a deceleration, just especially variable decelerations, because maybe they are the most difficult to interpret, I would say follow the TFCD rule. So T is a type of deceleration, and F is a concerning features. And CD, so C is the contractions, or like the repetitive. Um, I mean, if you check the contractions, you will know if these decelerations are repetitive or not. And then D, which is a duration of these decelerations. So if T and F are present, this means this is not white. Okay, so if you see type of variables are variable like type of decelerations are variable decelerations, that's one thing. If concerning features are present, then you have T and F, and this means it's not white anymore. But if you have a type that's variable decelerations, but they are not with concerning features, this means they are white, they are fine. But if the T and F are present, they are not white. So they can be amber or red. How should I know? So C is the contractions, so whether it's repetitive or not. D is the duration, whether it's less than 30 minutes or more than 30 minutes. So as we said before, If both C and D are positive, meaning that it's repetitive and duration more than 30 minutes, this will be red. If it's just one of them but not the other, so it's a duration more than 30 but not repetitive, or repetitive but the duration is less than 30 minutes, this is when we call it amber. So certain findings of our CTG could really be an indication for expediting delivery. So, of course, we discussed how to read the CTG, but there are certain situations that you have to be really mindful of as being very, very alarming to you. So, for example, the absence of variability is a serious concern requiring immediate review and a low threshold for intervention. Here we're talking about absent variability. So it's not just a reduced one, it's just absent. So you see like almost like a flat line. That's a concern that is not normal. If you see a reduced variability that is associated with other signs, one of the most critical signs are the rise in the baseline. So we mentioned that a rise in the baseline that's more than 20 is concerning. But if you see both of them, a rise in the baseline with reduced variability, the combination of these two signs is really worrisome. So you really have to take that, not just thinking about it as a categorization of the CTG, but the combination of these two signs is pretty much a strong indicator that the baby is not doing well. So another situation is any sort of reduced variability that is associated with any other changes in the CTG. So the presence of decelerations along with reduced variability is another worrisome combination. So I would say reduced variability with anything else is a concern. And absent variability by itself is a concern. So this is how I would like to say it. So now we learned how to review the CTG. We have 4 domains. We have to end up writing, when you report on the CTG, you have to write the 4 domains and give a color for each one. So when you do that, this helps you to categorize the CTG. It's not a categorization of the CTG. You still have one more step to do. So the categorization of CTG is either being normal, suspicious, or pathological. So it's normal or if all the features, all the 4 domains are white. It is suspicious if you just have one amber sign or domain, but the rest are white. It is pathological if you have either 2 amber signs or 1 red sign. Of course, if you have more than 1 red, it's still pathological. So it's very important, as we mentioned, to classify your CTG clearly as you go with the intrapartum care. So intrapartum CTG management guidelines include the following. If the CTG is normal, you just continue reviewing at least every 1 hour and categorize every 1 hour. If it is suspicious, but no additional risk factors are present, you just have to conduct a full assessment, including evaluating accelerations, because we said accelerations can be reassuring in the presence of a suspicious CTG. If the CTG was previously normal, review the possible causes why the CTG is now suspicious. One of the things could be the blood pressure changes. So you always check on how her blood pressure looks like, because sometimes she's hypotensive. Check on the contractions. Maybe she's over-contracting, she's having tachysystole. Check on the bleeding. Maybe she starts to bleeding and there are some placental abruption that you're missing. Maybe meconium, or maybe any signs of infection. So in this situation, when we have suspicious CTG, you're trying to check the causes. Conservative measures should be undertaken, including that you stop oxytocin if you're running oxytocin. Try to reposition the patient to her left side if it's not working, the right side, etc. Or maybe upright position. So these are typically the 3 positions we try: left side, right side, and upright position. Of course, not flat. The only reason why you would give IV fluids is if the patient is dehydrated. So if you think she's dehydrated or hypotensive, okay, but otherwise don't give IV fluids for no reason and never give oxygen. Oxygen doesn't help and it can harm the baby because of the production of free radicals. So if there is a concern about hypotension, especially in a patient that has epidural running, you have to check for anesthesia review. So this is also one important thing because we see a lot of situations when the CTG changes quickly after epidural or after epidural bolus. This is typically because of the drop in the blood pressure. And once you correct the blood pressure by the anesthetist, so the anesthetist will be just the one who will be able to fix the blood pressure for you, and then the CTG will be fine. If additional risk factors are present, such as slow labor progress, sepsis, or meconium-stained amniotic fluid, an urgent review should be conducted to identify the cause. Part of this assessment is to do a fetal scalp stimulation to assess variability or the need to expedite delivery. So it's very important, I would say, when you have a suspicious CTG, if that's only because of a reduced variability, I would just advise that you do a fetal scalp stimulation because sometimes that just confirms that everything is fine. But if you don't get a response, you have to be more worried. And the presence of other, especially in the presence of other risk factors. What if the CTG is completely pathological? So first, you have to exclude any acute events such as umbilical cord prolapse, placental abruption, or uterine rupture. So you have to do a full assessment that should be conducted to identify the cause, and then you may try some conservative management to see if that would help. But if the CTG remains pathological, an urgent review is necessary with a low threshold of delivery. So I would say, if you see a patient with a pathological CTG, few things you want to know. First thing, outside of the patient or like outside of doing an examination, you want to check on her blood pressure. So if the blood pressure is low, is hypotensive, especially in the presence of epidural, that could be the reason. Of course, if she's tachycardic, it could be another sign of dehydration. But you have to do an abdominal examination to check if there is any suspicion of uterine rupture or any suspicion of placental abruption. And definitely, you have to do a pelvic examination. First thing, to rule out cord prolapse. Second thing is to see if there is any bleeding or anything else. And third thing is you want to see if she's making very quick progress. So maybe you're examining her and she's now fully dilated. So you have to consider maybe expediting delivery in a different way. And you may not have to do a cesarean section depending on how close she is. So in the presence of acute bradycardia or prolonged deceleration, you have to rule out acute events, and this is very critical. So the cause should be reviewed, and you start preparing for delivery immediately after you see that. So you have to call the neonatal team as a part of your preparation to delivery. The expectation is if recovery occurs within 9 minutes, reassess, and depending on the risk factors, you may decide to either carry on with a cesarean section or whatever you're doing to expedite delivery, because if she's fully dilated, you may try to deliver with a forceps. But I mean, if you're planning to do a cesarean section, then if 9 minutes have passed and within these 9 minutes, the recovery of the CTG to the normal baseline happens, then you may have to reconsider whether you would like to proceed cesarean section or you just wait and see and hope for a vaginal delivery. But this really depends on the risk factors. So if you're concerned that there is a problem going on, you may just have to carry on with the cesarean section regardless. So whenever you see a prolonged deceleration, you just have to follow the rule of three. So basically, I mean, you get 3 minutes when you see the deceleration. So you're expected to start acting on that. So you have 3 minutes left for you to try to do conservative management and find out the cause and try to help the CTG to recover. If that doesn't happen, then within 3 minutes, she should be in the theater, because in 3 minutes, you should be delivering this baby. So every single stage should take just 3 minutes. So for you, the importance of this rule is you not trying to recover the CTG for more than 3 minutes. In these 3 minutes, you stop the oxytocin, you try positional changes, you do your examination, and if everything's still the same, then you have to go to the theater for that. So in brief, if the CTG is not normal, there are a few things you should do exactly like this. Check the history and the background. So know your patient background, just remind yourself of her story. And if there are any certain risk factors that you know about her from pregnancy or from labor. And then you have to check her vital signs, see if she's hypotensive, tachycardia, because that could be a clue. Review her contractions, very important. Check if she's tachysystole or not. That's very, very important. And then once you did that, you do your examination. So abdominal examination and then pelvic examination. And while you're doing the pelvic examination, just do a very good scratch of the fetal head without pushing the head up, of course, just to see if that will help with variability in particular. And your actions should include stopping oxytocin, repositioning the mother to the left or the right or upright position. You only give IV fluids if the patient is hypotensive, but it's not a routine, no oxygen whatsoever. The anesthesia review is requested if epidural, if we think that's related to the epidural, and the key to that is if she's hypotensive. Very important, if you think that she's a tachysystole, her contractions are 5 in 10, or like really not getting any rest out of the contractions, then you have to give terbutaline 250 micrograms as a subcutaneous injection. So if you're trying all that and nothing is really helpful, just please, please, please expedite delivery. So you have 3 minutes, only 3 minutes to try all what we have mentioned before you give the team your decision of moving to the surgical theater. So just always keep an eye. You check the history, you check the risk factors, you check the observations, but always know what you're checking for. So when you check the observations, you want to know if she's hypotensive or not, and if she has an epidural in place or not, if she's tachycardic or not. You're checking the contractions to rule out a tachysystole. If it's tachysystole, please consider terbutaline before you decide to deliver this baby. And you don't have to really delay anything. So you give the terbutaline immediately, and you still can move her to the theater, check on the baby in the theater before you do your cesarean section to see if the baby responds or not. So review the observations, review the contractions, do your abdominal examination to be sure it's not placental abruption, because if you think it's a placental abruption, that's a straightforward answer. Just take her to the theater and deliver the baby as soon as possible. Pelvic examination, be sure that the baby doesn't, or there's no cord prolapse, because it's another straightforward answer. And be sure that the babies does not respond to the fetal scalp stimulation. So when you know the cause, that will save you some time to know exactly what you need to do next. So if a CTG concern arises in the second stage of labor, an obstetric review is required for sure. So sometimes when you see a CTG change, that's pretty concerning. I would say like a pathological CTG. Sometimes active pushing should be discouraged and oxygen administration is stopped to allow recovery of the CTG unless you think that labor is really imminent. So that's very important, because sometimes people get excited, and if they feel like the CTG is pathological, they are trying to really encourage a woman to push more to get the baby out, or even increase the oxytocin to get more contraction to get the baby out. But it's not about how quick the baby comes. It's about the condition of the baby. Because if you are, I mean, the baby can tolerate like an intermittent hypoxia, like when the baby has a contraction, not much blood, then recovers, then gets blood. But if the contractions are back to back, no rest, then the baby hardly gets any blood, right? And you may deliver the baby quickly, but the baby will be a very poor condition. Just please don't just think about it as a matter of time. Just think about it as a matter of how much the baby is suffering. So if you think the CTG doesn't look right to you, always try to give the baby a break. You can slow down, stop the oxytocin depending on the CTG. Try to help the baby a bit. And you don't have to really sacrifice the quality of the CTG for the sake of getting the baby out. Because if the baby doesn't come out nicely, I mean, if the baby still have a way to go and the CTG doesn't look right, then you have to intervene to expedite delivering the baby rather than trying to push hard on the mom to push this baby out if the baby is not close. But if you think the baby is really close, like you can see most of the scalp of the baby, and baby looks like it's sitting there, just needs a push or two, then okay, we wouldn't say that you slow down the process because the possibility of the baby coming out within a few, I would say, seconds is high. So we would be happy to carry on with pushing. So that was it. I know the CTG, I mean, is a little bit challenging to read, but we have to be mindful that most of the poor outcomes of babies are because of us not being able to interpret the CTG correctly. And that's why there are so many systems of how we read the CTG and how we decide based on what we read. And I know there are different systems. There's the American system. The system we have illustrated now is the English system, the system that's supported by the RCOG and the NICE guidelines. I would say I prefer this system because I mean, I feel like it's pretty much detailed compared to other systems. So every single observations that you see in the CTG counts. So it's pretty much individualized. So it's not just like variable decelerations, late decelerations, early decelerations, it's it. It just gives you some landmarks about what you need to just observe to see if, for example, a variable deceleration is concerning or not. So I really appreciate that in the reading of the CTG, because I mean, we in the old guidelines, we used to call all variable decelerations are just fine, which is not true. And as you will like see a lot of examples for the CTGs, you will see a lot of CTGs that have variable deceleration that will never be right for you. You will never feel comfortable saying they are just variables, they are not causing any problems. So that's why they have to classify into concerning and non-concerning features. And the other thing is the fact that they valued the change in the baseline of the heart rate of the baby, which becomes increasingly recognized as an important feature. It's tricky because I mean, one of the things that really lead to poor outcome of the babies is intrauterine infection, which commonly happens at the time of labor. And unfortunately, they don't have necessarily a lot of signs in the CTG, despite the fact that they really can impact the outcome of the baby. So what I mean basically is the sign of increasing the baseline is one of those signs that could indicate either infection or hypoxia as well. So it's still a sign that could mean a lot, and that's why we have to be mindful of it. So again, I mean, it's pretty detailed, and the last version has been recently updated, so it's probably just reflective of the most recent sort of evidence. And that's why I really recommend using this system actually to read the CTG. And it's always good to just keep practicing by reading every single CTG that you see and avoid judging the CTG just by naked eye, just saying that's okay or not. Try to always categorize your CTG, justify why you think it's fine or not fine. And as we mentioned, you just need to take a segment, 10 minutes, to see what the baseline is, and then check on the variability within a minute. You can take different minutes and just see what is the most likely range of variability. Check on the accelerations, check on the decelerations. If you see decelerations, try to figure out which type the decelerations are. I would say pretty much most of the decelerations that we see are variable decelerations, but you have to confirm that. So just be sure that you don't take that as a rule and just judge on your own uh, if they look like a variable deceleration or not. And once you see the variable decelerations, you have to learn to practice how to read them, how to classify them, how to know if they are okay ones or evil ones, or what I say, with concerning, without concerning features, and then you have to be mindful of their duration and the frequency of these variables in relation to the contractions. So once you're able to do that, you will be comfortably saying that this is a normal CTG, is a suspicious CTG, is a pathological CTG. And with any abnormal CTG, with anyone that's not normal, you have certain set of steps that you need to do to decide what's going on and what you should be doing next. If you just follow this scheme in your mind, you'll feel like CTG is your area of comfort. You'll be very confident reading it and acting on it. These are some sources that I would recommend for you to read, and thank you so much for your attention.